So good morning, either afternoon, evening, everybody, because we have also someone from India, so it's evening. It's my big pleasure to launch the first the webinar series of the Technical Committee, Therapeutic and Diagnostic Systems and Technologies. I am Paola Saccomandi. I am the current chair of this TC, and I am really excited to have Dr. Chang as our first speaker. Dr. Chang received his bachelor degree in biomedical engineering from Johnson Hopkins University. He entered the medical scientist training program at the University of Wisconsin-Madison, where he obtained his MD and PhD degree with certificate in clinical investigations. He also completed his diagnostic and interventional radiology residency training at UCLA. And he stays as a member of the abdominal interventional radiology section. I think that the background and expertise of Dr. Chang is really special because he's a medical doctor with a strong engineering background. So he focuses on the diagnostic imaging and treatment of solid tumors with minimal invasive techniques, always taking into account the engineering problems and how to try to solve the challenges that we have in the thermal therapy and minimally invasive treatment with the engineering tool. So I feel really honored to leave the floor to Dr. Chiang, and thank you again for your time.
Thank you. Thank you. Very, very kind introduction. And I'm happy to be here. I know everyone is logging in from different parts of the world. So thank you for either waking up very early or staying up very late to I guess, listen to this talk. So I'm going to be talking about how I use modeling and engineering to improve device development and techniques in interventional oncology. And I'm going to maybe provide a little bit of a unique perspective because of my background as a clinician. So these are just my disclosures. So I guess you talked about my background a lot, and I don't know if there's trainees on here, undergraduates or graduate students, but this is kind of what I've done. And I always point this out, well, partly because when I'm in the clinical world, people always say like, you look pretty young. How long have you been doing this? And so I will say that I've been doing this for many years. But basically, this is kind of my training background. And so I did my undergraduate at Hopkins. I studied biomedical engineering. I used to be interested in neurosurgery and epilepsy. And so I did 4 years of research doing deep brain stimulation. And that's, putting the electrode inside different parts of the brain to stop seizures from happening. After that, I did I did the medical science training program. And so for people outside of the United States, this is like an NIH funded program that funds people to do both an MD and a PhD. And I did this at University of Wisconsin, which is a very strong engineering school. And I would say already at this phase, I was probably one of the very few MD PhDs who studied engineering. Most people are actually doing basic wet lab stuff, doing biology. They're doing immunology or biochemistry. And so I would say 90% of MD PhDs, even across in the United States, they do that kind of work. And part of it is because most of the MD PhDs actually in the US, they actually study those kind of wet lab skills. And so those are the kind of opportunities that are available. And so in this program, I spent 2 years in medical school. The first 2 years are just doing didactics, so doing biochemistry, genetics, anatomy, all these kind of clinical coursework. And then after those 2 years, I ended up doing my PhD, and I did it with in biomedical engineering in Department of Radiology. I worked with Chris Brace and Fred Lee at University of Wisconsin, and we studied, that's where I really sunk my teeth into doing engineering work. So doing microwave antenna design, modeling heat transfer, and using it to build devices to treat cancer, which I'll tell you a little bit about. And then that last 2 years of medical school is all the clinical rotation. So you're going through internal medicine, surgery, psychiatry, OB-GYN, all those different things. And so that's why you have a really nice exposure. It does take a long time. All that was 8 years. And so, a lot of my colleagues, they had kids in the beginning of the program. And then by the end of the program, their kids were like teenagers. So it was it's a pretty long process. But it didn't end there, unfortunately. So I ended up doing residency afterwards, and that's the part where you become a board certified physician and you learn the skills. So I went to UCLA and I did diagnostic and interventional radiology. So my first year was an intern where you're learning how to take care of people, and then 3 years of diagnostic radiology, which is learning how to read CTs, ultrasound, MRIs, and being able to, for example, run tumor boards and stage cancers and diseases. And then the last 2 years, I did interventional radiology, which is where you do all the ablations, the catheter-directed therapies. And so when people say like, well, how long have you been doing this? I always say, well, I've been doing it for like over 10 years, 20 years, many years. So that's kind of where my background comes. And this is kind of how I like to frame my kind of talks to show you like, I have an interesting perspective from both wearing both hats. And so how do I do all this? Well, here's my sample work week. On Mondays, I usually do diagnostic radiology. So I'm doing ultrasound, cross-sectional abdominal interventions, which is just another way of saying we do biopsies, drains. My ablations are actually on this day as well. It's considered a needle, going into the skin, into the tumor. On Tuesdays, I do interventional radiology, so it's vascular. So I'm doing catheter-directed therapies. And those are the cases where I'm putting a catheter inside a blood vessel. I'm either opening up a blood vessel or stopping a blood vessel from going, like, for example, in bleeding, you maybe want to stop the blood vessels. So that's interventional radiology. The patient's generally a little bit sicker, and so that's it's a pretty tough day. It can be a very busy day. On Wednesday is my research day or clinical workflow. Patients, for whatever reason, they love calling me on Wednesdays and Thursdays. Those are they're dedicated research days, but sometimes if I don't have time to do like a case on Monday or Tuesday, I'll put it on Wednesday or Thursday. And on Friday is my PET CT day. And so one thing that people don't think about when they try to build a cancer practice is you have to build that practice, meaning that you have to go advertise or you have to go meet oncologists. No one's going to just send you their cancer patients. But for me, I read PET CT. And so I get to diagnose and stage all the cancers on imaging. And when I see something that could be treated, I usually just call up the referring provider and say, hey, I just read your PET CT, but I can also, do ablations or TACE or Y90. And so this is kind of how I structure my week, every week of my life. So, and then I'm on call every 8 weeks. So, so for a call, for interventional radiology call, you pretty much do everything, a lot of traumas. So for example, in LA, we have a lot of, I'm probably in Milan too, a lot of car accidents and people getting into trauma. And so people who are bleeding but cannot get surgery, they call me, and it can happen any time of the night. It can be 3 a.m. or it can be like 6 p.m. So anytime someone's bleeding and they cannot stop it, they will call me. So you'll notice that this has nothing to do with oncology. A lot of inpatient work against lines, drains. Peripheral arterial disease are people who like throw clots down their legs and they're gonna lose blood flow or potentially lose their leg. That's what they call me. Pulmonary thrombectomy, so pulmonary embolism, so clots into the lungs, they'll call me. So every 8 weeks, I have to do this, and it's really bad when it's when there's an NIH grant deadline at that time. So so it can be a little bit hectic, but this is kind of how I structure it. And this is the way how I try to think about how you can do engineering and clinical work in a very productive way. Because I think most people kind of shift one way or the other. They do either 80% clinical and then maybe just a little bit of engineering research, or they do like all clinical and then or all research and very little clinical. I may have just reversed those. But basically, this is kind of how I designed my life. Is I do the diagnostic imaging is one specialty. The interventional part, which is doing the ablations, the TACE and Y90, is the part where you can actually treat patients. And then the engineering research it kind of feeds into both the imaging and the interventional radiology. So, so I always look at this idea of, I don't even know if I'm pronouncing it right, ikigai, which is, how to maximize the impact of your career. And so, what I love doing the engineering research, building devices, and finding, the ground truth for a lot of the clinical problems that we run into. What am I good at? Probably the research, but also at imaging and intervention. What am I paid for? I get paid a little bit for everything, but mostly from imaging, actually. Imaging is kind of what can support the department. And then what the world needs is they need my engineering research, but they really need my interventions. So for example, when people are bleeding, they probably don't care about my engineering research. They just want me to stop the bleed. So find a way to balance all these things, and that's how you can get a very productive and satisfactory career. Okay. All right, so let's talk about the meat of this talk. So I study hepatocellular carcinoma. This is the most common form of primary liver cancer in the world. Most of it is caused by underlying liver inflammation. So for example, hepatitis C, hepatitis B, which is endemic in Asian countries and African countries. But in the United States, it's becoming very, very common because of fatty liver disease. And so, in the United States, how we eat a lot of fried foods, very delicious, but can cause fatty liver disease. And not everyone responds to fatty liver disease the same way. There's some certain ethnicities that are more predisposed to it than others. And so I guess in Los Angeles itself, where there is a lot of Hispanics and Asians, I think those people have a higher risk for developing fatty liver disease, and subsequently a higher risk for developing hepatocellular carcinoma. And so that's why in UCLA we have a very high risk patient population, and that gives me kind of a unique insight into seeing what's the best treatment for these kinds of patients. This slide right here is what we teach for residents. It's a lot of things, but I just want you to look at this. This row right here is all about liver disease. So very early liver disease, very late stage early disease. And then they decide based on the liver disease and the amount of cancer, they decide these are the different kinds of treatments. So for example, you'll see that for what I do is mostly ablation, Y90, and transarterial chemoembolization. So this is all considered very early to intermediate stage liver cancer. So when people say, well, why don't you do this for late stage liver cancer? Well, the goal is not to at that point the disease has gone to different parts of the body, and you cannot target it safely with ablation or catheter-directed therapy. And I always tell this to my engineering students is we work on this because at this point the liver cancer is still considered curative. So we try to do these things at a very early stage. We try to diagnose these at a very early stage, specifically so when we do our therapies, we can actually cure the patient or at least bridge them to transplant. So what is an ablation? I think most of you have, just going down the list of people on the call, this is very introductory, but not everyone, but this is just in case you haven't seen it before. This is a minimally invasive procedure guided with CT and ultrasound or MRI to treat early stage liver cancer. So at the short and the long of it is that you put the needle and I'll show you a diagram. You put the needle through the skin into the tumor, heat comes out of the tip of the needle, and you basically cook the tumor. And you try to cook the tumor to the point where you can actually cook the entire, all the liver cancer cells. All the cancer cells will not be able to survive beyond the temperatures associated with ablation. And then you're done. So it's very simple, very easy to explain. It's usually done as an outpatient procedure. And so 20 years ago, they used to have to do surgery for these patients. They used to have to put the patient under anesthesia, open up the abdomen, and cut off this piece of liver. Very morbid, lots of complications. Patients would be in the hospital for weeks. There'd be a lot of blood loss and a lot of infection. This is just when people wake up, Most people don't even know this procedure has been done. They say, Dr. Chang, like, when do we start? And I say, you're actually already done. Please go home. So, and they're very happy. They just walk out. So this is a fantastic kind of therapy that we offer to our patients. This is how it's actually done. Patients is here, usually under moderate sedation and anesthesia. Under ultrasound guidance, you can actually see that you guide the needle through the skin into the liver, into the tumor. Heat comes out. You can see the hyperechoic microbubbles being formed from the heat. And then afterwards, you can see the post-treatment response. And so here is the tumor right here next to the IVC. And you can see afterwards, what you want to look for is that there's no residual enhancement of the tumor after therapy. After they go home, they come back to me every 3 months. We get an MRI scan, and you can kind of see here this hypo-intense structure showing the post-ablation changes. Again, there's no more enhancing components here. And so this is called a complete response by ablation. And so these patients do very well. I have patients I've been treating for over 10 years who they just get ablations every few years. They do very well. They don't get no other treatment. They don't need transplant. They're very happy with their therapy, and they can continue their jobs or continue their lives the way they were. So what about modeling? So, I study microwave ablation mostly, and so I always present this. Radiofrequency ablation was the most common form of ablation, from the 90s all the way to the early 2010s. The max temperature usually was, a little bit less than 100. And you're fighting two things. You have the source of the heat from the radiofrequency ablation, and then you have the solid tumor. And so you can model this as just a straightforward passive thermal conduction through the Fourier heat transfer. And so the rate of thermal conduction is proportional to the difference in the heat between the tumor and the center of the ablation zone. And so this is kind of a passive heating mechanism. The risk of that is that the perfusion from the liver can sometimes be very strong, and your heating may not be enough to actually overcome the cooling from the surrounding liver. And so you may have insufficient ablation zones, and this can predispose you to higher recurrence rates, especially if this tumor is next to a blood vessel. So microwave ablation is kind of what I studied during my PhD and during my residency. Microwave ablation heats through, instead of just passive conduction, it heats through dielectric heating. And so you're able to heat volumetrically, and you can heat through various kinds of conditions. So even if it's kind of dried and desiccated, which traditionally is thought as being very difficult to heat with just passive radiofrequency ablation, you can actually heat through charred and desiccated tissue. And so you end up have this active heating zone, you get water vapor, and you get much larger ablation zones. And the risk for that is, as opposed to radiofrequency, where you're not treating enough of the tumor, now you actually risk damaging too much of the tumor, plus surrounding critical structures. You have bile ducts, the capsule, blood vessels, diaphragm. I've seen people ablate through all of these things. Okay, so if you don't know where your ablation zone is at, you can cause very bad things to happen. The nice other cool things about microwave ablation is there's tissue-specific heating, so you can tune your antennas to deliver energy specifically into the organ that you're interested in. And again, because you are heating with active heating, you can actually, it's less susceptible to the heat sink effect. So even through perivascular tumors, you can actually heat through the tumors to heat through nearby blood vessels to completely cover the tumor. And so this is from one of my colleagues at Wisconsin. Very commonly shown figure, but you can show that microwave ablation, which is the blue line. Let me just explain. The y-axis is temperature. On the x-axis is the time of the ablation. You can see that microwave ablation does heat more to higher temperatures compared to radiofrequency ablation. And so this is why you're able to treat larger tumors, but you do have to be a little bit more careful. What happens when you miss? So this is the thing where potentially I could offer a little bit of insight of why it's important to know how to model your microwave ablation zones, because if you don't know where your ablation zone is going, you might miss and hit something you're not supposed to. So I don't know if people have seen CTs before, but this is kind of what I did my training in residency. Here is a cross section. So the way to read this is basically imagine a person lying flat, feet towards you, head away from you, and then you're just taking slices down this person's body, and that's what the CT here. And so basically, this is the liver right here. I'll just point out this is the liver right here. aorta, spleen. These are the two ablation probes going in. They're like little missiles going into the tumor, and you heat the tumor, and you're supposed to send the patient home, right? This is what happened afterwards. Patient was not doing so well in the recovery room, and this is not me, by the way. This is one of my colleagues, but yeah. So basically, this is a contrast-enhanced CT. You can tell because there's contrast in the aorta. And after they did the ablation, they pulled the antenna out. And then what do you see here? This is blood, actually. Blood right there. There's blood here, and this is all blood. And this is all blood right here. This is supposed to be lung, but it's supposed to show up black, but you show it's gray. This is all blood. So basically, the patient was not doing very well. And what happened is they actually were like, well, where's this guy bleeding from? This is what I mean by catheter-directed therapy. This is the aorta. This is the celiac artery coming out here, common hepatic. Don't worry about the terminology. I give a 1-hour lecture just on hepatic artery anatomy for my fellows. But all you have to know is that this is the liver. And the bleeding was not from the liver, but it ended up being from here. This is a blood vessel. This is called the phrenic artery. I'll show you a better screen, but this is the renal artery. This is a phrenic artery coming off the renal. So the phrenic artery supplies the diaphragm, so how you breathe. And kind of a quick run here, but you can see, I want you to pay attention to this, okay, on the next slide. We got into the vessel, and you can see that right there. Can you guys see that? So that is a bleed. So what happened is they had actually ablated into the diaphragm, and they had caused a rupture of the diaphragm over here, okay? No worries, because at least you found it. 90% of the battle is finding where someone is bleeding from, okay? So we put some coils here, and you can see no more blood flow there. So this guy was saved. But basically, this illustrates the reason why we have to be very careful, and we have to know where the ablation zones will be, because if you don't, you can damage critical structures. And then I'm going to get a call in the middle of the night, and I'm going to say, why did this happen? And you're going to say, I accidentally ablated part of the diaphragm. So, so this is why it's important to know where your ablation zone is. Benefits of computational modeling. Okay, so on top of just as an introductory note, we do a lot of computational modeling. The nice thing about it is it creates a very highly controlled environment to identify the effects of changing very specific input variables. So whether it's dielectric or tissue properties or different kinds of antennas, this kind of gives you like a very rough estimate of how your experiment's going to perform in real life. The nice thing about doing computational modeling is you can kind of focus on a specific variable at hand. You know, when you do translation, this will lead to fewer animal studies, decreased developmental costs, greater research efficiency overall. And on top of being a way to improve your research workflow, clinically, you can actually add certain complexities into these models that you may help you decide on your treatment strategy. So whether it's you know, a patient with cirrhosis and low water content in their liver, you can actually add that into your model beforehand and see, well, is my ablation zone going to get bigger or smaller in a cirrhotic liver? Similarly, you can also, with microwave antennas, optimize device settings before a procedure. Very briefly, this is kind of just a computational setup we do, is that we can specify the antenna geometry beforehand, and you can test different geometries. There's hundreds of different geometries you can play with, and design your microwave antennas. And we solve Maxwell's equations. I personally just use COMSOL, which is very user friendly. Solve Maxwell's equations for the electric field within the dielectric, and then within the electric field that spreads into the liver, you can actually calculate how much heat is being generated. And so basically, here's a SAR of this, what we call a dual slot antenna, that allows you to focus the heating towards the tip of the antenna and minimize the heating along the shaft of the antenna. And this is important because, you know, if your skin is right here, for example, you don't want to heat through the skin or the diaphragm. And so building the right antennas to suit your need is very important. Tool optimization. Most microwave antennas today are usually designed to deliver energy into the liver. and we use that for pretty much everything. But we know that, with computational modeling, here is basically this is an isotherm showing how the heat distributes over time. This is 50 degrees. As you get closer, it gets closer to 100 degrees. So basically, you want to make sure that where your tumor boundary are is at least over 53 degrees. So you can cook the entire tumor. This is the S11. So if you're familiar with Smith charts, this is the amount of power that's being reflected back into the antenna. And so you can see that as you get lower, that means less power being reflected back and more forward power is being delivered into the tumor. So the lower on this chart, the lower parts of this chart, this is frequency, shows that a lot of this is where it's most efficient. And so we did a previous computational study showing that if you're able to use a lung tune antenna, does it work as well in different kinds of organs? And so we can see here that this is in breast tissue, this is in lung tissue, and this is in bone, which is clinically relevant because at least at many institutions, they use liver-tuned antennas to treat all of these different organs. And so when you're talking about predicting the ablation zone, it can be quite different from what manufacturer says if you really know what if you really understand the tissue properties beforehand. I talked a little bit about this before. These are the different ways we can modify the antennas based on computational modeling. This is like a dual slot that we had created when I was at University of Wisconsin. And you can see that it does get a little more spherical ablation zone, and there's less of a tail, I guess, for heating. So it can be potentially a little bit safer for patients with tumors that are closer to the skin surface. We did a very brief study when I was a resident here, building a lung tune antenna versus a liver tune antenna. And so, you can kind of see this is like a ex vivo model that we had built, but you can actually hook up these. This is a pig lung that we had hooked up to a ventilator. And so you can actually test how different antennas perform inside in this ex vivo ventilated lung. So and this is like a very straightforward study to do. I mean, if your institution has animals, you can always ask for like leftover parts and test out your antennas. So the cost was essentially almost free for this study. And basically what we're able to show, again, this is reflected power, so part of your S11, although it's not on a log scale. And it's showing that, so again, the lower numbers mean it's more efficient. And we can show that in the lung with ventilation, a lung tuned antenna actually delivers energy more efficiently than a liver tuned antenna. And you can see here that the lung tuned antenna actually is able to create a larger ablation zone compared to a liver tuned antenna within the lung. And so I think this is very interesting study because in clinical practice, everyone pretty much just uses a lung tuned antenna. And so, the predictability is much lower. And I have clinicians always coming up to me and saying like, well, why does my ablation zone look like this? Well, I said, well, there's some interactions between the antenna and the tissue that are not being accounted for. So I'm going to move on. I'm going to talk about the heat sink effect. So ablation zones are very susceptible to the heat sink effect. Here's a colorectal metastasis next to the hepatic vein, this little dot right here. This was treated with, this is at that time, radiofrequency ablation. You can see that there's an ablation zone here, and there's a little bit of a residual vessel opening through here. And a lot of that residual vessel can actually contain viable liver tumors. And so sure enough, 9 months after that treatment, on this PET CT scan, you can see that this colorectal met was actually FDG avid. And so we have to be very careful when we're treating tumors that are next to blood vessels. Here's a study, and I'll just show you on here. This is an ablation zone. This is the inferior vena cava, which is this big vessel going through the liver that delivers blood back to the heart. So when you ablate, when you have tumors next to the inferior vena cava, you have to be very careful because you're have a very high risk for under-treating. So you can see here, this is all viable tissue right here. This is your ablation zone. So you can, if you have to treat very aggressively in these areas, because if you don't, you're going to leave viable tissue here. And this is bad because if there's viable tumor in this area and it goes into the IVC, the next place it goes is to the heart and then the lungs. And the lungs is one of the top 2 places that liver metastases go. So very important that you treat this adequately. This is a just an example of flow. This is a 4D flow MRI sequence showing how blood flow can change the shape of your ablation zone. So the red is the ablation zone that we create with microwave. And you can see that this causes this kind of indentation. The microwave ablation zone kind of heats around the blood vessel. Even though it's supposed to heat through smaller blood flows very efficiently, around larger blood vessels, you still have to know how it can impact your ablation zone. And so we had done this study showing what happens when you ablate through large blood vessels. And we can see here on the y-axis is the microwave ablation volume. On the x-axis is the flow rate. And so you can imagine as your blood vessel flow rate, which we identified with 4D flow, as your flow rate is faster and faster, it sucks heat away from the treatment zone. And you actually get smaller ablation zones. And that can be very important when you're trying to adequately cover the entire tumor. So this shows you that it's important to recognize the velocity of the blood flow prior to doing your ablation, because it tells you how much more power you may have to provide to adequately treat the tumor. This is an ultrasound image of an ablation zone. What you saw here is the microbubbles being formed. And what happens during ablation zones, another thing that we could potentially model, is that the tissue is being dehydrated. Just like when you try to cook a steak, you're removing water vapor from the tissue and you're desiccating the tumor. Now, what happens though? It's not an isolated process. There's a lot of things happening when you take water away from a steak, right? The steak starts shrinking, and that makes a big difference because a lot of the times we measure these tumors based on the size of the tumor. So if it's already going to shrink, then you have to know, and you didn't treat something adequately, then you may be tricked into thinking you actually treated something when you didn't. So I'll tell you what I mean. So this is another model that we did where we incorporated water vapor formation and transport. And so on this chart here, this just shows the temperature distribution of a microwave ablation zone. This actually shows the amount of water vapor being formed. So blue is liquid water, red is water vapor. And you can see that water vapor forms right here in the center where it's the hottest. And this corresponds to here, right? So all this is water vapor that you're seeing on ultrasound. You know, this is something that you can see that every clinician who's done this, they always see this on ultrasound, okay? Now, what happens when you link it to contraction, though, is we use a deformable mesh here on our image, on our model, and you can actually see this kind of contraction. And this is very similar to what you see in real life. And again, this is a very inexpensive study to do. Just find some tissue from your local butcher and do the ablation zone. You can actually see how the whole tumor, the whole tissue just contracts just like you do in the model. And I think this is something that you can capture very accurately with modeling. But just to give you a sense, this is what we do now. Before 3 years ago, they didn't even have this option to predict this in the commercial software. Nowadays, after millions of dollars of R&D, what they do is this is a navigation software that tells you where your ablation zone will be next to the tumor. But for contraction, they actually make the clinician decide how much contraction there is. So they just say, hey, do you think this is 20%, 30%, or 40% contraction? That's the best we have right now. So, you know, for the engineering students out there, very big need for something to accurately predict contraction in an ablation zone, because this is the best we have right now. And it's pretty silly to let the clinician decide how much contraction there is, especially if you don't know how much water, what the water content is beforehand. So again, this is the best we have. So I told you a little bit about how blood vessels can take heat away from a treatment zone and decrease the efficacy of your ablation zone. Something that we started doing is this thing called combination TACE ablation therapy. So TACE means transarterial chemoembolization. And so what it means is, you know, the thing about liver cancer, HCC, is that it's usually supplied by a single blood vessel. And so what we're able to do is we actually stop the blood flow going to that tumor, and we can actually create much larger ablation zones that way. So here is a standard case monotherapy ablation zone, a lot of perfusion around the treatment zone. But by doing transarterial chemoembolization, oh, and by the way, the chemoembolization part, we give some chemotherapy as well. So it's chemotherapy plus something to actually stop the blood flow. So with liver perfusion, we can do this transarterial chemoembolization, slow down the blood flow, and then create the ablation zone. And we get much larger ablation zone. So here's a tumor, here's the embolization, what we did, and then we did the ablation and get a much larger ablation zone than what would be normally expected with a single ablation probe. Here we were able to show using in vivo modeling that we're able to actually, when you embolize the liver, this is the ablation volume on the y-axis, on the x-axis, the amount of energy going into the ablation probe. When you embolize the liver, you end up getting much larger ablation volumes, actually, as expected. But there are certain pros and cons. The pros is, yes, we do get better outcome with combination TACE ablation. But there's also, because you're heating much more, you get increased complication rates. And so one thing that we've started to do is doing dynamic contrast enhanced MRI. Basically, this is an MRI sequence that allows you to model how much perfusion is in the liver. And we correlate the amount of perfusion with how much power is being, how large the ablation zone will be. So here's kind of our lab setup here. This is a pig under anesthesia. We're able to actually perform these kind of embolization, characterize the perfusional change on MRI, and then do ablations afterwards. And what we're able to show, and this is just more about the MR perfusion, showing that you can actually characterize, this is a dynamic enhancement curve, time and contrast. And you can see that this is pre-embolization and this is post-embolization. So there's slower blood flow going into the tumor. And what we're able to show here, at least kind of like the prior graph I showed with the 4D flow, is when you have more and more perfusion on the y-axis, your ablation volume will get smaller. And so when you compare this with the computational model, it actually matches up okay, but at least the trend is there. So the last thing, I know we're getting a little bit short on time here, so I'll talk about the future of modeling and how we can potentially augment ablation with other modalities. And so immunotherapy is something that's very in vogue right now. I mean, it does work. I've seen patients essentially cured by immunotherapy, so very important to have. And so one thing with immunotherapy is, though, that a lot of times the immunotherapy, they may not be able to identify the tumor antigen, so little pieces of tumor that the immune system need to recognize in order to sensitize it to kill the tumor. And so ablation is one of those things that can really help expose tumor antigens to the human immune system. So here's a case of an HCC. This is the tumor right here. We treated it with ablation. A few months later, this is the treatment zone, but we had a new tumor show up right here, okay? So this happens quite often. And so one thing we try to do is look at exactly what the tumor, what the heating zone is like around the ablation zone. So here is, again, the y-axis is the temperature. X-axis is the spatial distribution of heat, okay? So this is a 1-minute ablation, 2-minute ablation, a 5-minute ablation. And you can see this is the center of your ablation zone right along the needle. And you can see that kind of like you expect, this is your 1-minute, 2-minute, 5-minute ablation zone. You can see that it's very hot in the center, but it drops off as you get further and further away from the center of the ablation zone. And what we are interested in, because we know that nothing's going to really survive anything above 50 degrees Celsius, what we're wondering is about the areas where you have non-lethal hyperthermia. So the areas that are between 37 and 47 degrees, that area, that's the part where we think if there's viable tumor there, the tumors may grow even faster if they're exposed to this periablational non-lethal hyperthermia. This is kind of what it looks like, this congestive zone on pathology. So viable tissue, this is that non-lethal hyperthermia, and this is the actual ablation zone. So there's this quite area where if you have microscopic disease that you cannot see on ultrasound, CT, or MRI, then this can put you at risk for recurrence. So what we have done is actually look at this area, and we were able to actually look at the tumor cells and see if they're able to drop this key recognition surface marker. It's called MHC1. Basically, all cells have MHC1, but the tumor cells, some of them don't have MHC1, some have like intermediate amounts. Basically, if you have very little MHC1, your natural immune system will be able to pick these off and pick these cells off with what we call natural killer cell immunotherapy. And so just to show you, in this periablational non-lethal hyperthermia zone, we were able to show that by heating to 47 degrees, you can actually knock off all these MHC1s, and it will allow the immune system to actually pick up these cells. Now, a lot of these cancer patients, they have diminished amounts of these natural killer cells. And so what we did is we decided to give some assistance by giving some extra NK cells. And what you're able to show here, this is our tumor. This is just in vitro. Primary NK cells, IL-2 stimulated NK cells, and our supercharged NK cells. You can see that at 47 degrees, we can actually kill more of these tumor cells when combining it with this NK cell immunotherapy. We actually were able to do this in a mouse study as well, combining ablation with this NK cell therapy. Here's the mass of the tumor. You can see that there's significantly less tumor after you do partial ablation plus NK cell therapy compared to tumor alone. And this is, you can see the graph of the tumors. You can see that there's much better efficacy when you combine ablation with immunotherapy. And again, this is all based on the modeling showing that we're the peripheral zone where you have this non-lethal hyperthermia. So I think that's something that we can really leverage as engineers to collaborate with your immunotherapy colleagues. So just in conclusion, computational modeling, super helpful, critical for improving ablation outcomes. There's a lot of things we can still do with antenna designs. A lot of antenna companies out there. Ablation is a very common form of therapy we have today. It is considered curative in many cases, and so this is something worth working on. Modeling can give physicians a better idea of what final ablation zone will look like. It's about, as you use more powerful ablation tools, microwave, you need to focus on balancing safety with clinical efficacy. You want to be able to treat the entire tumor, but you don't want to damage surrounding blood vessels. So it's very critical that you know exactly where your ablation zone will be. The current standard is clinical experience. So people just kind of guess right now. So there's a lot of things you guys can do to improve accuracy of ablation zone prediction. Modeling will be critical for combining ablation with other therapies. And people who do modeling can take this to your fellow colleagues doing wet lab work and show them the advantage of combining their chemotherapy, radiation therapy, or immunotherapy with ablation, particularly using the hyperthermic zone around the ablation. And just as more of a kind of a global message, I think it's important to reach out to clinicians at your home institution. At UCLA, our hospital is right next to the engineering school, and most of the engineering students still do not know where the hospital is at. So I don't know how that happens, but there needs to be some more collaboration between the two. I was just at the IEEE EMBS conference in Orlando, and I think I was the only clinician there. I think there needs to be a little more engagement with clinicians, and if it's not them, it's got to be you. So someone has to do it. Advertise your knowledge and capabilities. A lot of the physicians, like clinicians, they don't know what they don't know. So even predicting ablation zone in the liver, which has the most research, I think a lot of people still don't know where their final ablation zone will be. And that prediction capability is even less in other organs, the lungs, the kidney, the bones, thyroid. People have no idea. There's so much more research that needs to be done. And on the engineering side, it's important to confirm that your projects are clinically relevant. So I do see a lot of projects that are good science projects, but may not be good clinical projects. And I think a very good goal would be to make sure that your projects are both scientifically interesting and clinically relevant. So with that, a little bit over time, but I mean, this is my lab website that I just put up. Collaborate with a lot of people. You saw my schedule. I'm very busy. So a lot of people are helping me out when I'm out doing clinical work. But it's a very big group of people, a lot of interventional radiologists, diagnostic radiologists. You can see I work with people in the School of Dentistry, School of Engineering. And so I think it's the only way to really push these kind of projects forward. So with that, I'd like to thank you for your time, and I'm happy to take any questions.
Thank you so much, Dr. Chang. It was really amazing. I have a lot of questions, but I would like to give priority to our attendees. Yeah, no, really, thank you. It was really, I learned a lot, and I got, someone raised the hand. No? Yeah. Yes, please.
Hello. Hi, Paula.
Hello.
Can you hear me?
It's Puya.
Yes, it's me.
No, hi, Puya.
How are you? And thank you very much, Doctor, for this very interesting talk. I learned a lot. So I have a question. Do you use CT guidance? Do you basically apply microwave ablation under CT guidance, or you use ultrasound for the sake of ablation? And my second question is that so basically we should manage the viable tumor cells that left in the margin of the tumor, and if that tumor is very close to the vessel, how do you manage this situation? How do you compromise? Because if we want to ablate more to get rid of the residual cells, it has risk for vessel wall damage in my opinion. So I would like to learn how do you manage this situation. Thank you very much.
Sure. Absolutely. Those are great questions. So for the first question, ultrasound or CT, I use both. It depends on how good you are with ultrasound. Ultrasound is very technically, the technical skills of an ultrasound vary from person to person. So I use ultrasound a lot. I think it's very important to have real-time live guidance of your needle into the tumor. But I know people who don't use ultrasound at all, and they just go straight in with a CT, and then they just check on CT to see how much they have to move. Both are being done. I use both. I use ultrasound and CT, and I think anyone doing ablations, they really need to be good at using an ultrasound machine. It's also not as easy as like point and look. Like I think there's a lot of subtleties of the different kinds of techniques you need to, for example, move the lung out of the way, or to go underneath the rib, or go from the back, or patient positioning. The other reason I like ultrasound is you can see the microbubbles being formed from the heat being generated from the ablation zone. Now, the microbubbles is not an accurate reflection of how much heat is being generated. The ultrasound is just very sensitive to microbubbles. So you can have a lot of microbubbles, but it's maybe not that hot. So, but I use it as a way to, if the microbubbles are getting close to a critical structure, then I might slow down. I might turn down the power, or stop ablating and do a CT just to confirm where my ablation zone is. With regards to your second question about perivascular tumors, one thing I look at is how badly does this patient need that vessel? So if it's a very small vessel in the peripheries, it's probably okay. But if it's a very big vessel, central portal vein, then I might be a little bit more careful. I may, in some scenarios, try to do catheter-directed therapy instead. I can also do irreversible electroporation, which is a theoretically a less thermal part of ablation, although it is a little bit thermal still. But yeah, I have to see how big it is. So for example, if it's next to the inferior vena cava, I just ablate like crazy. I don't care like that. It's very safe. There's enough blood flow to protect the blood vessel, so you can actually ablate very aggressively. If it's next to a bile duct, for example, then this is the part where I have to look at the patient. I have to look at the total bilirubin. I have to look at the synthetic function. I have to look at the labs of the liver, basically, and see how sick is this liver. Can I knock out this bile duct or blood vessel without compromising the patient's liver function? Because the worst thing you can do is you ablate someone and hit a critical structure and then cause acute liver failure, because that patient may not, they may have to go to the ICU, or even worse, they may have a fulminant liver failure, and potentially it can be a life-threatening kind of event. So very careful. I think a lot of patients have to, or a lot of clinicians have to recognize that. And, you know, one thing that you can do as engineers is help build better prediction models to say like, yeah, this will be safe.
Perfect. Thank you very much. I don't know if I have more time for asking two more questions, or
I'll let Paula decide.
Sorry. Quickly, Puya, because I have other questions.
okay. Yes, I want to know that do you use simulation for the ablation, and what percentage of error is okay for this due to the uncertainties of the parameters that you set in the model?
Yeah, so I've done simulation on just the very hardest ablations is what I've done. So I basically use it. I appreciate the question about error because it's very important. But I use the simulation just as a tool to get me in the right direction. So for example, when I want to know what an ablation zone will look like next to a blood vessel, I will plug in, I already have models existing. I'll plug in the velocity of the blood vessel, and then I'll see, well, is this vessel going to stay open? And if it looks like the temperature will stay under 50 degrees, then I'll just go ahead. But I will never use the model by itself. Like it'll be a combination of factors. So the error, I don't know if I can answer the error question, but I can say that this is just one of many tools that I use to get me started on the right foot.
Perfect. Thank you. Thank you very much.
Thank you. Before to leave the floor to Anna, we have a question in the chat from Andrea asking, what are the most critical parameters in your thermal ablation models?
The most critical parameters in the ablation model. Well, the most critical ablation parameters for any kind of ablation on the clinical side is going to be the power and time. That's the only thing you have control over, actually. So I would say those are the most critical. The things that potentially change the way the heat distributes, how the electric field distributes, would be the dielectric properties. And certainly you can keep cutting this into more and more specific, because certainly dielectric properties can be a function of temperature and water content. So so dielectric is also very important. The antenna design, I think is helpful for improving efficiency. But in general, the antennas used clinically are already very efficient. So hopefully that answers your question about the things I kind of think about. So I would say power, time, dielectric constant. Perfusion is also very important. If you go down to look at your modeling and look at the Penny's bioheat equation, those are the parameters that I kind of modulate.
Thank you. Now, yeah, Anna, you want to ask your question? Yes.
Hello, can you hear me?
Yes.
Hello, hi Paula, hi Jason. Thank you very much for the fantastic presentation. I have just a question about the last couple of slides on the combination between microwave ablation and immunotherapy. And yes, so if I understand correctly, like targeting at like, let's say, suboptimal or sublethal, let's say, temperature are more likely to initiate an immunogenic response. Is that correct, Jason?
Absolutely, that's right. So
Okay.
I think a lot of the times, we have a lot of times in our field, ablation, like we've always been advertising our role in creating immediate thermal cytotoxicity, because all cells will die in these temperature range. But if you go to your immunotherapy or biochemistry colleagues, these temperatures, not only do they kill the cells though, but they also prevent the tumor cells from having any kind of interaction with the with the surrounding immune environment, at least those that are exposed to these cytotoxic temperatures. And so what we can really do, and this is where modeling really help, is quantify and characterize the areas right outside the immediately cytotoxic zones, because those cells will still be alive. Those cells are the ones that will be able to interact with the immune system. And so these are the areas that we need a lot more investigation on to see. And this is the area that this would be your calling card for reaching out to your immunotherapy colleagues, because they don't, most of them have no idea that we can create temperatures in this range as well.
Yeah, no, and to me, it makes total perfect sense. My question is more from clinical perspective, and let's say human mindset, in a sense that to create this synergy, you would like to have clinicians that intentionally deliver these. Did not kill the entire tumor, is that correct? So from your perspective and your experience, how likely a clinician is willing and able to deliver sublethal temperature in a clinical setting?
That's a fantastic question. And that's a question because you understand that, you know, you're offering curative results, but you're also saying, well, I'm going to leave something alive. So normally these cases, the patient population is a little bit more advanced. So they have multiple diseases. You can't treat everything because, I'll back up. People on immunotherapy have very advanced disease. So they're not going to have like one tumor and you're going to just leave part of it. They're going to have lots of different tumors, both sides of the liver. They'll be very sick patients usually. These patients usually don't have like a very good straightforward option. And in those cases, you can say, well, I'll take care of some of these, but there's others that'll still probably be, there'll probably be some others that will be viable. And we're hoping that it interacts with the immunotherapy.
Thank you so much.
Yeah, so most of these are in different kinds of clinical trials. So if you look at like IMbrave 150, they combined ablation with immunotherapy. The Rowan trial is combining Y90 with immunotherapy. The Emerald trial, Emerald 3, is combining TACE with immunotherapy. So everyone's trying different permutations because they know that these kinds of technologies that we have can locally activate the immune system. And so, you know, and maybe make their checkpoint inhibitors work better when they have this kind of local tumor presentation.
But
so,
these clinical trials, if I remember correctly, like for example, IMbrave phase 3, like they selected patient who already had received or surgery or microwave or radiofrequency ablation. So do you think that they were selected to receive intentionally as, let's say, some optimal ablation, or they just selected based on the I don't know, the database?
Yeah, that's a great, yeah. So the IMbrave, I think they were mostly early. It was mostly early stage patients, and that made it a little bit unique. So that particular trial, I think it was early stage. But there potentially could be like smaller imaging occult like tumors that are not visualized, and that's the point of adding the immunotherapy. So they didn't leave anything behind, but they were saying, well, if in these kind of diseases, if they have little microscopic disease outside of the tumor, then the immunotherapy would be able to pick it up. And if they're able to heat it up with this periablational zone, then potentially it'd be a way to combine the ablation with the immunotherapy. I will say, like, for the advanced stage, it can be a little bit tricky. So what normally, so not with microwave ablation, but in my practice, I get a lot of people asking me to do cryoablation with immunotherapy. for not HCC, but with sarcoma. And these patients, they have no other options. And they ask me, they say, hey, Dr. Chang, can you just ablate one of my tumors? And then while I'm on immunotherapy, you know, so they're kind of just trying. So the HCC world is there's a lot of standard practices already well established. And so when you go to tumor board, people are going to be arguing about these different trials. But outside of HCC, in like the sarcoma world, head and neck cancers, I think these are areas that people are kind of trying these kind of partial ablations plus immunotherapy. And so especially the sarcoma world, I think that's the area where, you know, everyone's asking me to do ablations with immunotherapy. Because there's no good treatment. Immunotherapy by itself does not work that well.
Mm-hmm. No, thank you so much for the comprehensive and instructive answer. Thank you.
Mm-hmm.
Yes, yes. Thank you so much. I would like just to make a question / comment. I really appreciated your studies finding the best frequency for lung with compared to liver, because yeah, we also experienced an experimental study with a commercial microwave device where the manufacturer say, okay, these are the results for ex vivo liver. You can use the same settings to get the same ablation zone for the lung, which is completely false.
Definitely not true. Definitely not true.
Definitely not true. So, and I'm really surprised, because we struggle a lot with research. We are pushing things so far, but then still those are the devices which are sold. So clinicians have this information, and it's yeah, completely crazy.
Yeah. Well,
Yeah.
that's the issue. This is the point here about physicians do not know what they do not know. So they don't know that there's this discrepancy because most people have never done an ex vivo study or an in vivo study. They do patients, and they don't know that there's a huge difference between those two kinds of models. And from organ to organ, there's very few that have done ablations in like a pig lung, for example. And so I think this is the part where a lot of the engineers can help highlight, maybe help illuminate the knowledge gap right there and say, hey, look, like these are actually totally different. And I guarantee you, most physicians, when they hear that, they will say, oh, you know, you're probably right. We don't actually know. But the problem is that these ablation companies, you know, who are they? They're advertising to the clinicians. So the clinicians don't know better. But if for me, myself, I always tell, you know, the microwave ablation companies, like, hey, you need to have better characterization. Like these ex vivo versus in vivo models don't really work that well. You need to have, it has to come from the clinician side, and it's up to you to sort of as the engineers, to inform the clinicians that, you know, what you have right now is not enough and it's not safe for the patient.
Yeah.
So I think it's very, very big unmet need for this kind of collaboration.
Mm-hmm. Yes. Thank you so much. It was your presentation and yourself. You are the perfect bridge between the clinical and the engineering world. So I'm really happy that we could have this space, listen to you, and learning from your experience. It was really a reaching moment for all of us.
Great. Yeah. No, thank you. Yeah. Very happy to give this talk.
Thank you. I'm waiting for you in Milan.
Yeah, I'm there. And
yes, I think we can say goodbye to everybody, and thank you again, Jason, for your brilliant talk.
Absolutely. Thank you. Yeah, thanks everybody. If you have any questions, feel free to reach out. That's my lab website. And I mean, you can just Google my contact info as well. So
Great.
All right. Thank you very much.
Thank you again. And thank you
everybody.
to all the attendees.
Bye.
Okay. Have a great day or evening or night. I don't know.
Wherever you guys are from.
Thank you again. Bye-bye. Bye-bye.